welcome back to Vet Wrap. Today we have Dr. Kathryn Hogan. Hey. Who loves these things, but anyway.
Super excited to
Now we're going to talk about proton pump inhibitors from now on, PPI.
Yeah, which I am super excited to talk about.
Yay, good. And the reason is because
I did some research in this as part of my residency training. So I looked at healthy dogs and I gave them proton pump inhibitors, so omeprazole, and then I saw what it did to their gut microbiome. And unfortunately, I had to end my study early because we had quite a high number of adverse effects, which was interesting and was not anticipated to be as high as it was. So these were healthy owned dogs, no previous history of gut issues, and more than half of them ended up with either vomiting, diarrhea, or both.
So you started this, backtracking, you jumped right in because it's so fresh in your mind. I had this with a PhD. People would start me and then they'd just, and I'd go. So you started it but had to finish it early because the negative alterations, gut biome.
Yeah.
But can we go back a little bit? Why did you do the study?
So I guess there's always been a question about the impact of PPIs on the gut microbiome, and it's something that is not particularly well documented. There are some newer studies coming out that show some changes, but they've predominantly been done in lab settings, so controlled animals, beagle colonies, whereas this was looking at the average dog that we see.
Cool. Now, as a surgeon, microbiome sounds like the normal bacterial flora of the stomach specifically?
So the entire gastrointestinal tract. So,
cool. How did you look at all now I'm jumping way ahead. Okay, so not just gastric.
Not just gastric. So essentially whenever we are changing anything significant within the gut, so obviously our PPIs are designed to reduce the acidity within the stomach, but there's a downstream effect from that. So if you change the pH of the fluid that is entering the duodenum, you're going to have an alteration to the gut microbiome that is there.
Further
and then
down.
From there, your metabolome, everything else starts to progressively change. So that's where we get our alterations.
Now I need you to be honest.
Yeah.
So in my experience when I've had a research project, it's because something's annoying me. Either because there's a lack of knowledge or because it doesn't seem quite right or because the accepted wisdom doesn't seem to work. I guess it's called being observant. But so you must have had an annoyance.
I guess my annoyance is probably that we overuse PPIs and there's still this preconceived idea that it's a benign drug. It doesn't have any side effects. It's completely fine to see this. But the reality is that in practice, and I'm sure you're the same, we do see a lot of animals that we put on PPIs that end up having an issue with them. So whether it's they're off their food or they develop diarrhea, it's not an uncommon thing to get that phone call a couple of days later.
So so that I understand, you had client-owned dogs.
Yep, completely healthy. They were from the vet school that I worked at, so staff or students.
Of course. Okay.
Yep, and they were Victorian only, but from different areas. They had no history of previous GI upsets. They had not been on any medications recently. They were on a stable, consistent diet. They were up to date with their parasite control. They were over a year of age. I controlled as much
strict,
as I could for this.
And so you gave them recommended doses.
Yep. So
you weren't doing like does the dose change study?
I did. So we did 0.5 or 1 mg per kg twice a day.
Okay.
There was not a significant difference between the number of dogs that had adverse effects, whether we were doing 0.5 or 1 mg per kg per day. And unfortunately, because we had to end it early, the microbiome component of it, we have limited information, but for the ones that we did have, we did see a trend towards dysbiosis. So,
and omeprazole, it was omeprazole
just
in
omeprazole,
isolation. Okay, so you gave the dogs omeprazole, and then you did some magic. So how did you sample? Did you sample? What were you doing?
We did sample. We were looking at feces only. So it was collected by the owners, and then I would rush out on a Saturday or Sunday morning to pick it up and take it back to the lab to freeze it and
later on blend it.
Yes, later on blend it and send it off. So fun things like that.
Yeah. Okay.
Yep.
All right. And you've mentioned that you had to finish early. So So the study was stopped because
Because we had
dogs?
so many adverse effects. So
Okay.
within sort of generally 2 to 5 days after starting it, we were having more than half of our dogs develop either vomiting or diarrhea or both. And that was one of our reasons to discontinue. So we didn't actually end up completing that first week for the majority of dogs that went through the study because we had so many adverse effects.
Okay.
Yep.
So if they started vomiting, they discontinued.
They had to discontinue.
They had diarrhea.
They discontinued. So if it was
half of
significant
them.
enough, we did have a couple that continued if they had sort of mild to moderate diarrhea and their owners were willing to tolerate that.
Yeah.
And they did tend to have more dysbiosis compared to the others in the cohort that didn't have gut upset. But there was no significant difference otherwise in these dogs.
So that will get published eventually?
Eventually, yes. Hopefully in the next 6 months.
All right. Now the exciting, well, it's not more exciting. So we do these things.
Yeah.
You've done this study and you've obviously read every possible publication around not only omeprazole but esomeprazole and H2 blockers.
Yeah.
I'm guessing Pharmacokinetics as well?
A little bit. It's probably less of my area of interest, but it is obviously from, I guess, a brachy and the type of dogs that you see. Of course,
I'm going to take you down the brachy path. Come on.
Probably more interesting from that perspective. But I've done a bit of reading around that too.
Yeah. So how has it changed your use of PPIs? Oh, well, omeprazole.
Well, I guess the biggest thing is really there's the consensus document looking at the rational use of gastroprotectants, which is an ACVIM document, which is available to everyone. It's very easy to download. And as far as consensus documents go, it's actually quite an easy read. It is not too technical. And they do go through each sort of section really nicely in terms of indications and what the evidence is to support the use in those cases. So I think the biggest thing for me is really looking at making sure that there is an actual indication for the use of a PPI, which is going to be things like, is there evidence of or a high degree of suspicion? So, for example, you have seen gastric ulcers or you have a dog that has melena, which would be supportive of gastric ulceration. So gastric ulceration is the number one. Then I guess reflux, regurgitation, in particular where you are concerned that there is esophagitis specifically. And then also there's a few other less clear indications. So things like theoretically maybe higher stage renal disease or dogs that have portosystemic shunting or acquired shunting where there's an increased risk. But again,
that's a bit borderline.
A little bit borderline. And then the last category is those dogs that do strenuous exercise. So if they're off running the Iditarod, they probably would benefit from having a PPI.
Because they're predisposed to gastric ulcers.
They're predisposed to gastric ulcers with, significant strenuous exercise.
Yeah, like the sled dog thing. Yeah. Okay. All right. So if my dog is vomiting,
what would you do, House?
Don't know. Send it to medicine. What do you think? I'd probably fast it, but it's sort of tempting.
Yeah. So actually there's no supportive evidence that giving a PPI when you've got gastritis or vomiting on its own is beneficial. Yeah. So the idea that...
So if you've got HG, PPI is probably contraindicated?
Contraindicated. So I guess when you think about HG, generally what we're talking about is actually the blood is colitis associated. It is not gastric associated.
Yeah.
So when you think about how a proton pump inhibitor works, it's going to block...
Wrong end.
Yeah. Acid suppression from the parietal cells of the stomach. There are no parietal cells in the colon.
Yeah.
So it's not going to help with that at all.
Yeah. Okay. The big one, the elephant in the room is the brachycephalic.
Yeah.
Actually, the elephant in the room is the publications around anesthesia.
Yes, and this is the problem that we always have.
Because there's been a bunch, hasn't there? There's been a bunch of papers looking at how long it takes to change pH.
Yep.
A bunch of papers of various either PPIs, H2 blockers, prokinetics, whether or not they can minimise regurgitation events and during anesthesia.
Yep.
And what if they do regurgitate, what's the outcome there? So can I throw the the not so smart thing? Because there's always I feel obliged in the brachial space, but I'm sure other people feel obliged in another dog space to think about using a PPI plus a prokinetic prior to the anaesthesia.
I guess my big question is why?
Because everybody else is.
Yeah. I mean, if everyone else is jumping off a cliff house.
As long as there's a nice bit of water underneath and it was fun.
So I guess it is thinking about what you're actually trying to achieve with that.
Yeah.
Because in terms of a PPI, is a PPI going to reduce reflux under anaesthetic? Well,
some papers say that it might.
Not significantly. So it doesn't reduce reflux. What it does is it changes the pH predominantly is the main thing that we're looking at there.
And that's, yes. So, okay, let's list out the questions here. So the first question is, when do I have to start a PPI to actually change gastric pH?
Let's take it back a step further.
Okay.
Let's think about what are our goals for this in terms of what your outcome for a dog going under anaesthetic that's a brachycephalic is.
Well, no aspiration pneumonia.
No aspiration pneumonia.
Yeah.
Okay, so when we think about that and we think about what our PPIs do or how we can stop aspiration pneumonia, using a PPI isn't going to reduce significantly your incidence of reflux under anaesthetic.
Right.
It's not going to reduce vomiting. It's not going to reduce nausea in the post-operative period. Yeah. And there used to be this whole thought process that, because we take often PPIs to make us feel less nauseous because it helps with heartburn and those sorts of things that it will work the same with dogs. Yeah. But if we're worried about nausea, we should be using an antiemetic. A PPI is not an antiemetic.
So what's that? Meropitant.
Meropitant, yeah. A PPI is not going to change the likelihood of reflux or regurgitation, particularly if you're just using it as a
So no Gavestron.
No, not gonna help.
Not that that's a PPI.
Not that it's a PPI. Yeah. I mean, look, it might help to coat the esophagus. Those sorts of things from, I guess, a damage mitigation perspective can potentially be beneficial.
But that's the other belief is that if I change the pH and it's not as acidic, then I won't damage the lung parenchyma to the same extent.
Yeah. So I guess if you are worried about that, the other big factor to think about is if you're actually reducing your acid suppression sufficiently, you're going to get a change in the bacterial composition of the gastric fluid. So instead of going from, if you do happen to accidentally aspirate, a fluid that might cause some caustic injury with a secondary bacterial infection, you're now going to something that is going to cause a primary bacterial aspiration pneumonia, which is what we see in people. So there's a significantly higher risk of community-acquired pneumonias in people that are on PPIs in hospital because they might accidentally aspirate and then it's more bacterial load that's actually going into the lungs then.
So you've made it worse, not better.
Yeah.
Damn.
Yeah, which is unfortunate.
So hang on, but I still want to do this. So let's just hang on to another thread somehow.
Okay.
So you're saying I'm not protecting the lung. I might be making it worse because I go from a caustic injury to a true bacterial pneumonia.
Yeah.
And you'll want me to believe that it's not going to reduce regurgitation events.
It's not going to reduce regurgitation. We're just reducing the pH. So if you've got severe esophagitis.
So how do I use it? There you go.
Yeah. So I guess the thing is, if you've got a patient that is coming to you and you're examining it before you're thinking about doing your brachysurgery and you ask them your standard questions, that should always include things about reflux and regurgitation.
Yeah, absolutely, like daily or weekly or monthly.
Yeah, exactly.
So,
and if you've got a patient that is routinely refluxing and regurgitating, it probably has esophagitis. And that would be a reason to appropriately treat that in advance.
So just one tablet the night before?
No.
Why not?
Doesn't work like that, house. So when we think about how PPIs actually work, so PPIs bind to active parietal cells.
Yeah.
So that means that it's only going to work on the cells that you're actually secreting acid at that point in time.
Oh, yeah,
So
yeah.
you're not going to get every single parietal cell in the stomach immediately blocked and completely blocked and stopping acid production. So
what you're saying is that the proton pump inhibitor works on only active parietal cells.
Yep.
But they're not like just light switches.
No,
you eat
they're
food
not.
and they all turn on.
No, definitely not.
Oh.
So, I mean, you think about yourself, like,
Yeah.
you know, if every time you smelt something delicious, suddenly in your stomach, every parietal
just go
cell.
and eat it.
Yeah. Every parietal cell
I
started
have no
making
restraint.
huge
So mine
amounts.
are all on, okay? Anyway, you were saying.
Hopefully not every dog is like that. But if you were doing that, you would end up with a pH that is far too low,
Yeah.
and you would end up with consistent damage.
Okay.
So
Gastriosophageal, yeah.
exactly, it depends on the level of stimuli that you're getting,
Yeah.
as to how many of those parietal cells are going to be turned on. But what that means in terms of dosing and medications for these dogs is that they're most effective if they've actually been on it for more than just a single dose.
Yeah.
It needs to, ideally, depending on the drug that you're using, Esomeprazole has some studies looking at it that show that within 24 hours of 1 mg per kg twice a day, we should be getting to that kind of target range that we aim for gastric ulcer healing.
Yeah.
So that's at a minimum, but omeprazole itself actually is looking at sort of 2 to 5 days to do that.
Okay.
And the other thing to, I guess, remember is that once they're bound to these parietal cells, it's an irreversible binding. So it takes time to build up to that point.
Yeah.
And it's going to be more effective the longer you have them on it.
Oh, so the omeprazole binds and stays on.
And stays on. So
And how long does it stay on for?
until the cell dies off and we get a new one growing through. So it's irreversible binding.
I had no idea.
There you go.
Okay.
Learn something new every day.
I did. I had actually never thought about how omeprazole works, but
Yeah.
I didn't realise it was actually
Yeah.
once it bound, it was there, that it was done.
Yeah. And this is like
So you have to actually turn over your gastric mucosa to
get new.
So is that why you
cells.
shouldn't stop PPIs abruptly?
Yes, exactly.
Yeah.
Because you want to, and I mean, you can stop it if you've been using it for less than sort of 3 weeks,
Yeah.
4 weeks, somewhere in that range. That's fine to stop it abruptly. But if you've been using it consistently for a longer period of time than that, there is a risk of rebound, hyperacidity, although it's
Theoretical?
more theoretical. It's
Okay.
less well-defined in dogs.
Yeah. So I have my brachy. It doesn't regurge. But now I'm worried about anaesthetising it.
Well, aren't you worried about anaesthetizing it anyway?
Yeah, yes. But, I'm now feeling, I haven't got my little protective rug called, I gave it some Esomeprazole or Omeprazole pre
So you
and
it makes
metoclopramide
you
just to chuck that in.
feel better. That's
Yeah,
all that it's
yeah.
doing. It's not necessarily making the dog feel better.
Okay.
So I guess
So I'm not achieving much at
you're
all.
not achieving much. And I guess the big thing for if we're wanting to stop reflux under anesthesia, the biggest things that we can do are in that perioperative period for these patients.
Yeah.
So things like making sure it's appropriately fasted, making sure it doesn't have a stomach that's full of fluid.
Can we overfast, do you think?
I think we potentially can,
Yeah.
but I don't know that I have any strong evidence.
No, but it seems to
for
be the
that.
shift, isn't it?
Yeah.
Shorter and shorter fasting periods.
Yeah. So I think appropriate fasting,
Yeah.
make sure there's no one wafting chicken past its cage as it's getting, ready to go in.
Pre-medded, yeah.
Pre-medded and ready to go in. And then doing all the things that you would do for, say, for example, a dog that has megaesophagus or is at risk of reflux or regurgitation. I'm sure you're doing this already, but like keeping them upright when you're tubing them, make sure that the cuff is done up while they're still in an upright position, having them so that they are in a less horizontal and slightly more angled upright position where the head is above the thorax and the thorax is above the abdomen. Pop some towels under its chest, pop some more towels under its head, or tilt your table. All of those sorts of things are going to help.
Use gravity.
Use gravity to your advantage. Avoid things that are going to put too much pressure on the abdomen. There's lots of things that you can do as a clinician that are actually more effective than giving a PPI in these cases to help reduce reflux and regurgitation under anaesthetic.
Yeah. So essentially the message is if they're not a frequent regurger, so daily, weekly, then there's no added value and maybe a detriment because you change it to a bacterial, or not rich, but an acidic
higher bacterial load.
regurgent to a higher bacterial burden. Yeah.
Yeah,
okay.
absolutely.
So what do we do with the more frequent regurgit? What's the sort of recommendation there?
And I guess there's no direct studies saying, yes, do this, yes, do that.
Okay.
But from my perspective, I think if you've got a dog that is frequently regurging and you're concerned that it has esophagitis, treat the esophagitis, that poor dog.
Yeah.
Like, I would have them on medications, so a PPI and maybe some sucralfate for sort of soothing the esophagus for at least 5 days.
Now I'm wandering off.
Yeah.
Because you said esophagitis.
Yes.
But so many of us think hiatal hernia.
Well, I guess they're both going to be together. You're not just going to get...
But how many dogs with hiatal hernias need an anatomical correction of their hiatus?
I don't know. That's probably...
Very few.
Yeah.
Very few. So I just wonder, every bulldog has an anatomically different hiatus compared to long-nosed dogs, We sort of have shown that.
Absolutely.
Yeah, we're not fixing them.
No, we're not. But you're changing by altering their sort of nasal cavity, you're altering the pressures that are going to be pulling that through. And inflammation is going to be part of that too.
But that dog that regurgitates frequently, I think a lot of people just go, well, it's got a hiatal hernia, but has it? Has it got a hiatal hernia and upper airway obstruction and esophagitis?
Yeah. But I mean, if it is refluxing regularly and it's doing that on a daily basis, there is going to be some component of heartburn or inflammation there that is going to be uncomfortable for that dog. And we should be treating and managing that appropriately. Yeah. I guess the other thing is if you are concerned that your dog is going to need a PPI, having it started well before you're planning on doing surgery is going to maximise the effectiveness of it, but also give you a chance to make sure it doesn't have any adverse effects.
Like your study.
Yeah. So that way you're going to know that, yes, it definitely gets diarrhea after this. We're going to stop it. We're going to give it a chance to recover and then we can do our surgery because we know that this is not an appropriate drug for it, but we also know that the diarrhea it gets afterwards, if you had given it at the same time as surgery, you're not going to know whether that's because of
PPI or anesthesia or surgery
or anything else.
Yeah. Okay. Cool. So, metoclopramide. Actually, no, because you like this one more, famotidine.
Why?
Every time.
What's the point?
Well, yeah, but so there's a suggestion that, and there's a trend emerging of esomeprazole let us down. Sorry, omeprazole let us down, so we went to esomeprazole. Esomeprazole let us down because essentially the approach has been give it because.
But I guess the fundamental problem is that.
Yeah, but hear me out. Give it because, but the fundamental problem is we're doing it the wrong way around.
Yeah, we're trying to treat for a theoretical problem and treat all of these dogs as being exactly the same when they're not. They should be treated as the individuals that they are.
Yeah. So now there's suggestion that famotidine will be better. Yeah,
sure. If you want to use it as a continuous rate CRI for 24 hours beforehand at a really high rate, it will work to reduce.
Oh, but there's suggestions that it's actually more rapid onset than esomeprazole or omeprazole.
With the CRI, yes. But it's a very high rate.
It's not a single intravenous injection.
It's not as a single intravenous injection. That was with a CRI, that study.
Okay.
So we do need to look at, I guess, these things. And when we're talking about changing them, yes, some of our H2 receptor antagonists will work faster than a PPI, but they're not going to be as effective because if you've already got binding to those receptors or like the other receptors, because they're looking at the non-gastric side, so the sort of more blood side. Yeah. So you can still get stimulation of other receptors that will still stimulate gastric acid production.
Yeah.
Your PPIs block your proton pumps, which are the ones that are directly allowing acid to go into the stomach. So they're the only ones that are actually going to stop that, irrespective of any of your other sort of stimuli.
Yeah. Okay. Yeah. So they're both either side of the barrier, aren't they?
Yeah. Yeah.
Physiology is awesome.
Physiology is fun.
I haven't actually walked in here having done a little study to think about that. So I'm thinking, that's pretty cool. Yeah. Okay. So famotidine, not a great alternative. Well, not the Messiah.
Not the Messiah.
Just a naughty little boy.
Again, we're fundamentally not asking the right question here.
Yeah.
Which is, what do these patients actually need?
Yeah.
And I think treating them assuming that every patient that's a brachycephalic that goes under anaesthetic needs some sort of proton pump inhibitor or something that is going to change the pH shows a fundamental lack of understanding in
what you're actually
trying to do.
Yeah. So your question of why is the big question.
Yeah.
So we don't regurgitate, no advantage. We do frequently regurgitate 5 to 7 days, twice daily dosing.
Yeah. Yep.
Understanding based on your master's project that maybe half of those dogs will get vomiting and or diarrhea, which is always counterintuitive because you're giving it for, well, not vomiting, for regurgitation, but stuff comes out the front end, doesn't it?
But you've made a really good point there. Yeah. You've made the assumption that pretty much everyone does, that this is for like PPIs help with vomiting or PPIs help with diarrhea. And one of my other sort of little research areas was looking at how vets in Australia actually prescribe
or
PPIs.
perceive PPIs,
Yeah, and so the majority of them were using them for inappropriate reasons, and they were predominantly for things like vomiting or diarrhea.
So PPIs won't help us with vomiting and diarrhea.
Will not help you with vomiting and diarrhea. They will potentially make it worse. So you could be giving these drugs to dogs for an initial cause that could have been gone within 24 hours, but it's now persisting because you're giving it a PPI. Yeah.
And you've just assumed it's still got the same problem.
Exactly right.
There you go.
Yep.
See, I'm so focused on brackies, I don't think about these other things at all. All right. So I got famotidine into the conversation. Now I want to get metoclopramide into the conversation. So what does metoclopramide actually do, by the way?
So metoclopramide is going to be a prokinetic.
Yeah.
And so when we're talking...
But does it actually...
In the esophagus, if you're using it at a very, very, very high rate, so our standard CRI rate for a normal dog in hospital with some GI upset that we're trying to use as a prokinetic is 1 to 2 mg per kg per day.
And why are we doing that?
In terms of in hospital? Or
with a dog with...
So it might have ileus, say, for example, and we're trying to encourage the gut to move a little bit more.
Yeah.
There is a study looking at 8 mg per kg.
So instead of 1, 8.
Yes.
8 times.
8 times higher dosing. Yeah. And that did help to reduce the impact of reflux and regurgitation, the amount that they saw in dogs under anaesthetic.
And they were beagles, weren't they?
I think so, yeah.
Yeah, it was like a really controlled study.
It was a very, very controlled niche study. Yeah. And again, that's not looking at the population of dogs that we normally see.
Yeah.
And it doesn't take into account that there are a lot of adverse effects with metoclopramide, particularly those high doses. So we do need to be really careful with it. Yeah. So it's not something that we should be just using willy-nilly.
All right. And because it's coming into the American-based publications, what am I going to say? Cisapride, yay. So a little bit tricky to get hold of, but we're reading about it.
Yeah.
And it's also being presented as another solve-all.
Yeah. It's
actually in some brachy protocols that have been published to use Cisapride pre-anesthesia to reduce regurgitation.
It might help a bit. And I guess this is probably slightly better, but again, it is not a benign drug.
Like causes hyperexcitability and diarrhea and tachycardia and
a whole lot of other things that are also going to potentially impact your anesthesia.
Yeah.
That could actually be more critical for your patient than it having reflux that it doesn't aspirate on.
Right.
So I think you have to weigh up the risks and benefits. And if you've got a dog that is really, really, really high risk, has aspirated before, that you don't think that you're going to be able to control the airways with appropriately, then maybe
laryngeal tieback.
Yeah, exactly.
That's where people keep looking at it.
Yeah. That might be a case where you consider it for a standard brachy that you have a tube in and you have control of its airways. I wouldn't be.
No.
I don't know that the risks of the drug really
outweigh the benefit. Yeah. Okay, so the journey so far is, as a resident, you noticed and got uptight and upset about the use of omeprazole.
Went on a crusade.
On a crusade because you were observant. You said, why are we giving this to dogs who got gastro essentially?
Yeah.
And they're vomiting. That doesn't make any sense.
Yeah.
So you gave healthy client-owned dogs omeprazole, hoping to measure their normal bacterial flora and if it changed.
Yep.
And had to stop the the trial early because half the dogs had vomiting or diarrhea.
Yep.
And the other half did have a degree of dysbiosis or change in or bacterial flora.
Yep.
And so based on all of that and the reading around, really what the big message is prescribing culture, if that's the way to put it.
Yes, absolutely.
It has been misdirected.
I think so. And I think a lot of that is those myths and misconceptions that we have about omeprazole, that it stops reflux, that it is an antiemetic, that we can use it for sort of gut upset, that it is fundamentally a benign drug, and it's not like any other drug that we use.
So if we break it down into the two predominant misuses, it's for HGE in the vomiting diarrhea dog. It actually might make them worse. And it's definitely not helping them.
Absolutely.
And it's in the perception that it will reduce the risk of regurgitation and lessen the impact of regurgitation associated with anaesthesia, so prophylactic choice. Okay. And so what we need to ask ourselves continuously is why?
Like, what are you trying to achieve with this drug? And if that is your goal, is this the right drug to be achieving that? Because, as we said, if the goal is to stop aspiration pneumonia, a PPI is not going to do that.
Isn't going to do it, So if we have the HGE dog, we're just not going to use PPIs,
just don't use
proton pumps anymore. It's no benefit. If we have the dog that we're concerned about who has documented history of frequent regurgitation preemptively for a week, knowing that we might have to stop them because of the adverse events. And if they do well, do we continue with those through the anaesthesia period?
I think it depends on the individual patient, and it also depends a little bit on what your drug protocols are going to be in that post-operative period as well. Because when we look at PPIs and things like non-steroidal anti-inflammatories, which I guess is one of the other prophylactic areas that is a lot of misuse. We know that for dogs that are concurrently using a PPI and a non-steroidal anti-inflammatory, there is an increased risk of duodenal ulceration, which is obviously significantly harder to manage and control than gastric ulceration. And that's a combination of, your intrahepatic recirculation and where it comes out of the duodenal papilla with your NSAIDs, as well as the dysbiosis caused by the PPIs. So if you're planning on using NSAIDs for a period of time afterwards, maybe consider
be careful.
Be really, really careful with that. And I would probably recommend avoiding it and using something else or stopping your PPIs. So
get them through the anaesthetic event. And then be worried about the mix of meloxicam and omeprazole, essentially.
Absolutely.
Or carprofen and
whatever your
omeprazole, whatever your non-steroidal choice is. Okay, well, that's actually something to be well aware of, isn't it?
Especially for the surgeons out there.
So. Yes, absolutely. So that's got the dog who's regurging and identified pre-op. What about the dog who wasn't, or the dog that has been, but either case regurgitates during anaesthesia? What's our protocol there?
So I guess, again, depends on the severity of it and what you're concerned about. So as we said before, all those preventative things that you're doing are the most important things. But if it has actually refluxed and you've seen it, suction it. Dilution is the solution to pollution. So
not peritonitis.
But if we reduce the acidity of that area quickly, we're going to get less esophagitis. So we want to flush and suction and just try and reduce the pH. And then I would usually just suggest something like sucralfate that's going to coat the esophagus, reduce pain and discomfort, at least in people. That's one of the things that it can do. There's less evidence in dogs. But
so you're managing the esophagus at the moment?
I'm managing the esophagus because that's the area of problem.
And the trachea/lungs, you just have to rely on your
You're going to have to
ET
depend.
tube.
Exactly right. You should have a well-cuffed ET tube. You should be checking that every time. You should be suctioning or checking the back of the throat before you're waking them up to make sure that there isn't.
So the problem with the brachy, though, is that they sit there with the ET tube in. That's great, but eventually you have to take it out.
Yes.
Because they're aware, but their gag isn't completely returned, and then they regurgitate.
But I have noticed, I think with your nurses in particular, a lot of the time they're sitting there and they're holding the brachies upright during the recovery phase.
They do,
That's a huge thing.
And that's the thing,
That's just as important. We would do the same thing if it was, say, for example, a megaesophagus dog. You would sit there and you would hold it upright and
I might get you in when I do a 35 kilo retriever with the laryngeal tieback. Kathryn, can you hold this dog upright?
In terms of all right.
Yeah.
I mean, those sorts of things, like we do it for our patients as well. And again, we've got really nice wedges in radiology.
So just position them.
Positioning is really, really important. And worst case scenario, if you do have to have them where they are laying down, try and encourage that kind of bit of an angle. But if you have to, then having head elevated but nose down.
Over the edge,
so that at least that way, if anything does come out, it comes out.
You can go downhill.
Yeah.
Cool. All right. Is there anything else we need to know?
That's a good question. I'm sure there are lots of other things that I could complain about with PPIs, but I think that's
well, what dosing though? Like, there's a question.
1 mg per kg.
Because it used to be half a mg per kilo once a day.
Yeah, that's not enough, and it's not. There's
Is
enough.
that Kathryn says it's
No,
not enough?
there's enough studies out there to show that it doesn't do anything to change the.
And ESO's the same dosing.
ESO's the same dose, and definitely twice a day. Like, we've got really good studies that show that twice daily dosing is going to be enough to change gastric pH.
Yeah.
That said, we don't actually have a goal gastric pH for ulcer healing for dogs.
Yeah.
We're going off the human recommendations.
Yeah.
So there's always that caveat with it. We may find out, in 10 years' time that actually we can get away with a lot lower and it's fine.
Yeah, but we don't know
for
yet.
now, we're just going off what they do in human medicine. Yeah.
Cool. All right. Well, thank you.
That's okay.
We can talk. I'll get you to talk about how to manage aspiration pneumonia next.
Oh, God.
It'll be fun. That's never fun. But anyway, all righty. And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.